Okay. Yeah, we'll get going here. All right.
Do it.
Okay, so I'd like to welcome everyone to this virtual event. This is our seventh year already hosting Michigan State University's College of Human Medicine's Your Health Lecture Series. Thanks for taking your time out of your busy schedules to join us tonight. So my name is Todd Tiano. I'm a professor in the Biological Sciences Department at Grand Rapids Community College, and I'm the coordinator for tonight's event. Our sponsors for this free public event are GRCC, MSU College of Human Medicine, and Spectrum Health. At GRCC, we offer accessible and affordable education to a wide variety of students, whether it is for a transfer student or for a student enrolled in one of our degree programs. GRCC is a great place to start your college education. For more information about our wonderful programs, visit our website at grcc.edu. Now I'd like to introduce our speaker tonight for tonight's event, and his name is Dr. Daniel Havlichek Jr. And I'll say a little bit about our fine speaker. So Dr. Havlichek graduated from the University of Michigan Medical School in 1981. He did his internal medicine residency and infectious disease fellowship at Henry Ford Hospital in Detroit, Michigan. Dr. Havlichek joined the faculty at Michigan State University in 1986 and has held a variety of clinical, educational, and administrative positions in the Department of Medicine since then. He is currently professor of medicine and microbiology, past chief of College of Human Medicine Infectious Diseases Division, and past program director for the Infectious Diseases Fellowship. Dr. Havlichek teaches regularly in the College of Human Medicine and for the Internal Medicine Residency Program. He retired the first of this month. Dr. Havlichek's academic interests continue to be diagnosis and management of skin and soft tissue infections, HIV, and infectious disease prevention. And with that, I will hand the mic over to Dr. Havlichek.
Okay, great. Todd, can everybody hear me? Can you hear me?
Yes. Yep.
Okay. And might as well put the screen up, I guess. And while you're doing that, I'd also like to thank everybody for taking time today to join us and to listen to what we've got, or what I've got to say about COVID-19. I was told this was going to be a kind of a mixed audience. There'd be non-medical people, medical people, and pretty much anybody was allowed to sign up. So I've tried to craft this lecture for all audiences. That of course means for some it's going to be too simple, and for some it's going to be too complicated, but I'll do my best. This is not going to be a lecture for residents and attendings in terms of how do you manage a COVID patient in the hospital. You know, this is a broader lecture, and if that's what you're looking for, I'm afraid you might be a little disappointed. But we'll have time at the end for questions, and I'm more than happy to answer any of those. In terms of the screen, which I don't have, Todd, I don't have the first slide.
Okay, it is showing to us. I can see it. You're sharing properly.
You may have to use that
Okay,
sliding bar.
that. Okay, there we go. There we go. I have it now. Thank you. I chose the title about what we've painfully learned so far. And I put the word painfully in there because there have been a lot of mistakes that have been made in both the diagnosis, treatment, our understanding of SARS-CoV-2 and COVID-19. And, you know, it's just kind of the way it is when you're confronted with a new problem. Mistakes happen. With every mistake that does happen, though, we get a little better at managing these things, and we learn a little bit more about these things. And we are making progress in terms of managing the SARS-CoV-2 outbreak. So with that, I'm going to move forward fairly quickly because I am on a bit of a time crunch. So one of the things that I wanted people to understand is where SARS-CoV-2 fits in the spectrum of coronavirus. So coronaviruses are RNA viruses. There are a lot of RNA viruses, including influenza, but it has a very large, what we call genome, a lot of genetic material. Now, there are hundreds, literally hundreds of coronaviruses in animals. They're kind of like cold viruses. And there are a few that are in humans as well. Most of these don't really cause much problem for people. And unfortunately, though, there are a few that do. The first one, and I hope you can see my pointer, is the SARS-CoV virus that occurred in 2002-2003. This resulted in infections in 30 countries and 784 deaths. After this happened and people started looking for these coronaviruses, there was an outbreak that was described in 2012, 2013 in the Middle East. This was named the Middle East Respiratory Syndrome Coronavirus, or MERS-CoV, and there have been several outbreaks in the Middle East since. Interestingly, though, there's also been an outbreak in Korea in 2015, and that I think we'll come back to that in a little bit. The most recent coronavirus is, of course, SARS-CoV-2, started in 2019, and at this point, as we all know, about 1 million deaths worldwide and some 39 million cases. For definitional purposes, I just want everybody to know that COVID-19 is the name of the disease that we have, and it stands for 2019, the COVID infection of 2019. And the SARS-CoV-2 is actually the name of the virus. And this was previously called nCoV-19, but you don't have to worry about that. Okay, it's called a coronavirus because it looks like a crown, right? Or the sun's corona. And if you looked at this schematically, there are these spikes that come out that basically mimic either the corona, the sun, or the crown. And that's how it got its name. Some people want to know that. Now, genetically, and this is where we get a little bit of science involved. Genetically, the coronaviruses, and I said there were hundreds of them, fall into certain kind of families. And so the ones that we're going to talk about today are over here in the right upper corner, and in kind of this left middle section, or the right middle section. The SARS-CoV virus, the first one that was identified in 2002, resides about here. The SARS-CoV-2 virus resides about here, and the Middle Eastern coronavirus resides about here. And so I want to just take you all back a little bit, that if you are in a situation in February or March of 2020, and somebody asks you, well, what is SARS-CoV-2 going to do? You're going to look to what SARS-CoV did and what the MERS-CoV did, because we really truly didn't know exactly what SARS-CoV-2 was going to do, and we've had some painful lessons along the way. Now, where did the virus come from? Everybody wants to know that, and I do too, frankly. But I'm getting a call from Grand Rapids. Does one of the moderators need to talk to me? If not, I'll keep going.
No.
Okay. So where did the virus come from? Nobody really knows. Okay, there's really two kind of prevailing hypotheses. One is what you'd call natural selection, and that is that one of the animal coronaviruses either transferred to another animal, right? And then there were some mutations, and then that virus transferred to humans, or there's a idea afoot that this transfer actually happened person to person to person to person, and that there was no really intermediate animal. There's evidence, I think, on both sides for that, but still we don't know exactly what the right answer is. The second way that this could have spread, so to speak, is that we do know there was a virology lab, a biosafety level 3 virology lab in the Wuhan area, and it's very reasonable, I think, to expect them to have been working on coronavirus. They had a problem in their country many years ago, killed hundreds of people, the virologist would be expected to, look at that problem to try to, either get a vaccine or something else. So it's very reasonable to think that they were working with coronaviruses in that, biosafety lab or biosafety level 3 lab. And lab mistakes happen. I had a lab and know people that have labs, of course, and we all know that mistakes do happen. So that's another feasible way, I believe, where the virus could have come from. As you would guess, the Chinese government shut down that lab immediately after the outbreak, and people haven't been allowed in, and all the researchers are sort of quarantined, and nobody can get to the data. So, there's a lot of hypothesis generating, in terms of could there have been a laboratory mistake there? Again, I don't know the answer to that, and I don't think anybody truly does, but it's possible. This is a picture of the coronavirus on a respiratory epithelial cell, and you can see in this right-hand panel how it kind of looks like the sun with all these little spike proteins coming out. And again, that's how it got its name when people first saw it through the electron microscope. Over here on the left, though, I want to show you the vast number of viral particles that are coming out of this cell, and how you can imagine the cell was damaged and destroyed secondary to this coronavirus infection. Okay. For the people that like the science, the basic receptor, or the receptor for this coronavirus, is the ACE2 receptor. It stands for angiotensin converting enzyme 2 receptor. We know that it binds to that receptor, enters the cell. A lot of complicated things happen once it gets into the cell, gets reassembled, and then released to go and infect, other cells. This is where many of our drugs work in the test tube. This is where hydroxychloroquine works. It prevents this all from happening. It's where chloroquine works. It's where remdesivir works. And so as we talk about some of these treatments, usually this is the machinery that gets kind of mucked up. And it's obviously better to have these drugs on as early as possible if somebody has an infection, because once the infection gets going, it's kind of hard to stop. Okay, so the question of SARS-CoV versus COVID-19, okay? SARS-CoV, we know, was an animal coronavirus that jumped host in Guangdong province, China, in 2002. There were 305 cases there, and then one person left Guangdong province and stayed in what's called the Metropole Hotel in Hong Kong, and he stayed there one day. That person spread the coronavirus to 10 other hotel guests, and those guests spread disease basically around the world. The Metropole Hotel, as I understand it, is near the airport. And so there were cases then in Hong Kong, Singapore, Toronto, and Hanoi. And many of you will probably remember the quarantines that occurred in Toronto when this happened in 2002. But this pales, frankly, in comparison to COVID-19. The SARS outbreak happened in 30 countries. About 8,000 people got SARS, and there were about 800 deaths, okay? It burned itself out, or the social distancing worked, or the masks worked, but the last case of SARS was reported in 2003. Mortality rates, generally about 15%, 10 or 15%, depending on where what study you want to look at, but it's all really very close to 15%. And the interventions that worked against SARS were what we said, and I still think do help for COVID-19, and that's basically social distancing and quarantine. So here we are in 2003. There was some, kind of more voluntary level A quarantine going on in Taiwan, did not control the outbreak. There was a much higher level of quarantine that then took place because you could obviously see the number of cases was radically increasing. And then after about 6 weeks or so, and if you do the math here, you'll see that there are no more cases. And this is that magic number of 6 to 8 weeks that everybody talked about in the beginning, that if we can quarantine everybody and isolate everybody within 6 to 8 weeks, COVID-19 will go away. And that was a painful, I guess, mistake that we made, because that did not go away after 6 to 8 weeks, as we all know. So one of my kind of favorite quotes, and those of you that have heard me talk before may remember this, but I always love this quote. There are known knowns and there are known unknowns, but there are also unknown unknowns, the things that we don't know that we don't know. And basically stuff that you don't even ask questions about. There's things that don't even cross your mind. So that happens with SARS and with COVID-19. So let's talk about a little bit about transmission patterns, because that's one of the things that's been most relevant, I think, in trying to control COVID. This is the first published paper in the New England Journal concerning COVID-19 infection. And basically, you can look at all these things. There's lots and lots of data on it. But if you had exposure to wildlife, well, that didn't really happen much. That was only 2%. There was a time when people thought that, people acquired this from animals. Did you have contact with an ill Wuhan resident? Well, that was pretty kind. That's 72%. Incubation period for the disease, well, the median incubation period was 4 days, with what they call an interquartile range of 2 to 7 days. Okay, well, that's relevant information. And the patients who had fever on admission, well, that was about 50%, it was 44%. So this is, one of the things that was reported heavily in the news in February. Actually, it would have been reported in March, because this came out at the end of February. Other things, that were reported, basically that individuals did have fever during their hospitalization. People focused a lot on fever in the beginning, and cough. 70% of people had cough as part of their symptom complex. And so it kind of became the mantra that, these are the things that you have to watch for. Days from infection to symptom onset, most people are going to get sick within a week, and days from illness to the first medical visit when you come to the hospital, also about 6 to 10 days. And we get this kind of concept, headlines. I call them headlines, or high yield. The med students love the high yield stuff. Incubation periods, 2 to 7 days. Half of the people with fever on admission, 70% of the people have cough. Half of the people have shortness of breath, and most of them had contact with an ill Wuhan resident. But when you're epidemiologically trying to control something, right, you have to go beyond that, right? And it's not what you don't know sometimes that gets you into trouble. It's what's there in plain sight that you ignore that does, okay? And what you ignored by having this all just in plain sight was that about a third of the people with COVID-19 had no contact with anyone that was ill from Wuhan. Okay, I mean, that's a lot. When you're trying to control an epidemic and you're letting a third of the people where you don't know where they got it, I mean, that's a challenge. Half of the people were afebrile on admission. Half of the people were not short of breath on admission. A third of the people didn't have cough. So a lot of people are relatively healthy and just walking around prior to becoming truly sick. And also epidemiologically, 25% of the patients developed illness more than a week after exposure. So there's a pocket of people that, even though you're at that 7 to 10 days, well, now we're at 14 days, well, about 10% go up to 21 days. So far, epidemiologically, we haven't had a problem with that. But this is a challenge for the epidemiologists and the policymakers to say, well, where do we draw the line? Should we quarantine for 21 days? Should we quarantine for 28 days? Back in the day, 14 was the number chosen. And frankly, it seems to have stuck pretty well, although as you'll see, we still have COVID cases throughout the United States. Maybe we should go to 21. And the authors of that first article basically knew something was up. There was more to it than what they had truly reported. And this is the last sentence of their article. Some patients with COVID-19 do not have fever, and they do not have radiographic abnormalities on initial presentation. And this complicates the diagnosis. Okay, and I think all of the physicians in the audience agree that sometimes it can be very difficult to know who does and who does not have infection with COVID-19. Now, are these people pre-symptomatic or asymptomatic? We'll get to that in a little bit. Okay, so how easily is SARS-CoV-2 transmitted? Well, very easily is the answer. This is the well-documented case of a person who came from Wuhan to Korea, or went from Wuhan to Korea. He was a textile worker, went there for a job and came back periodically. January 20th, he returned to Korea. Actually, from what I had heard, he heard they were going to close Wuhan. So he wanted to get out of town before they closed. Human nature being what it is. So in January 20th, he arrived in Korea. January 22nd, started having a little chills and muscle pain, but nothing really to speak of. January 25th, he's concerned that he was getting sick, and so he contacted Mahjong Hospital and was ultimately admitted and placed in a negative pressure room. Next day, he was confirmed to have COVID-19. Keep in mind, we didn't have COVID-19 testing at this point. Korea did. But also keep in mind, Korea had lost many people in 2015 after the MERS outbreak, the Middle Eastern Respiratory Syndrome coronavirus outbreak. So they were much more sensitive about this issue. And of course, they're right next to China. And so they're much more sensitive about having it spill over into their country. The transmission, though, gets more interesting. The index patient gave the virus to a friend at a restaurant on that first day. Patient B then transmitted it to his spouse and his son and to the church colleague within just a few days. So it's very easily transmitted by some people. And this gets us to the super spreaders point, and we'll get to that in a second. So this index patient initially, when he was admitted to the hospital, had no respiratory symptoms, normal blood pressure, normal heart rate, normal temperature, normal respiratory rate, normal physical exam, no pharyngeal injections, clear lungs, negative chest x-ray, and multiple normal labs. And what I say, and still say today, this man would not have been admitted or isolated in any hospital in the United States in January. He would not have met admission criteria. He would have been sent back out into the community. And probably even into March, he would have been sent back out into the community. So anyway, the man gets hospitalized. He does then get sick. He gets fever, dry cough, and ultimately does okay. He has some minor consolidations and cough, but recovers generally uneventfully. So that's that. So it's spread easily. Well, how easily? Well, what is the secondary attack rate? Once somebody has COVID-19, what's the secondary attack rate? We have two bits of information. We got lots of information about this. I've chosen these two. This is the cruise ship that was stranded, I guess, for lack of a better word, off the coast of the United States for some days to weeks. And the contacts were monitored after they were off the cruise ship. Among all the contacts, there was a 0.5% rate of transmission. Household members, 10% rate of transmission. So the closer you are to somebody that's sick, the more likely it is that you're going to get sick. Okay? Korea, same thing. They looked at the first 30 cases that were diagnosed in Korea, and among all the contacts, and they followed 650 contacts, up to 650 contacts per case, 0.6% is the rate for all these contacts that they followed. And for household contacts, the rate was again 7.6%. So about 10%, arguably, of household contacts acquired COVID-19 if they were living with someone who had COVID-19. Otherwise, it's about 0.5%. Now, super spreaders and super spreading events. This is something we didn't know about. This is one of those painful lessons that everybody found out about. And there was a choir practice that had 61 attendees, including one person that was symptomatic. And if there's anything that we've learned now, is if you're symptomatic, stay home. But a symptomatic people are very, very likely to spread. They would be considered super spreaders. This person had 30 confirmed, or the people that attended the choir practice were part of the choir practice, had 32 confirmed and 20 probable secondary cases with an attack rate of 53%. Unfortunately, 2 people died out of this exposure. There were 3 people that were hospitalized and 2 people died. So, we certainly want people who are sick to stay home. Those people are considered super spreaders. And we consider things like singing or yelling or just making a lot of noise and making a lot of spittle, if you will, when you're talking, as a super spreading event. And that makes us all very nervous about sporting events and even choir practice, those kind of things. So it's likely some of this was, of course, facilitated by close distancing, but it was also likely that it was worsened by the act of singing. Okay. The other thing that we've gotten burned on with COVID-19 that didn't happen with SARS is asymptomatic carriage. And we have learned over the 6 months, I used to say we've learned over the years, but with COVID-19, it's only been since about February that asymptomatic carriage is really very common. And again, the Koreans, they were really on top of things. They identified an outbreak that I think was involving, 3,000 people in an area, and a number of them were sick. So they screened everybody at this point. Of the people that they screened, they had 303 positives, and they quarantined these individuals. Now, when we talk about quarantine here in the United States, it's kind of stay at home and, play with your dog. The quarantine that these people had was different. They put them up in a dorm. They had given them cell phones. They checked in with them twice a day. They did periodic PCR tests to see if they had COVID-19. They had clean areas and dirty areas. They were examined by physicians regularly, and they weren't allowed to leave until they were negative for COVID-19 or for SARS-CoV-2 on the PCR test. So of these 303 that were originally quarantined, most were symptomatic, 2/3, but 1/3 asymptomatic. And this is where we get into this pre-symptomatic or asymptomatic thing. These asymptomatic people, these 110 asymptomatic people, a lot of them, actually the majority of them, 89, continued to remain asymptomatic. They did not develop symptoms. Only 20% developed symptoms. So there are about, if you look at the total number here, 29%, or about 1/3, almost 1/3 of the people in this exposure outbreak remained asymptomatic and arguably could have spread the disease to a loved one or coworker. So asymptomatic carriage is different than with SARS-CoV, and it was a painful lesson that we've learned. Okay. So clinically, what does COVID-19 do? Well, most of the time it's pretty mild. And, people get a mild cough or a mild pneumonia, and then they get over it. And that's good. That's great. 15% or so people start getting severe disease, and this gets it to about a hypoxia or a lot of lung involvement, more than 50% lung involvement. And then critical disease, respiratory failure, shock, multi-organ failure. Not managed as inpatients because they are mild. And it says my internet connection is unstable. Let me know, guys, if I need to stop or log back on. Fatality rate, according to the CDC, is 2.3%. And approximately 10%, though, of the people who have had significant symptoms continue to have symptoms at 2 months. And that is a phenomenon that needs more understanding and more vetting. It's a little unclear what's all that about, and that is going to have more information to come. Thrombotic abnormalities are also the thing that we're very concerned about in patients who had COVID-19 or have COVID-19, and that for the non-medical people is where blood clots form. They can form in the legs or they can form in the heart. Sometimes they move. If they move from the leg, they can go to the lung and cause what's called a pulmonary embolism. That can kill people because you don't get enough oxygen then if a blood clot goes to your lung, or if it goes from your heart to your brain, you have stroke. So these thrombotic abnormalities are very, very serious and taken very seriously. And a lot of patients who are, in this situation get some form of anticoagulation. I think actually most will because they're at least bedbound, but some get more aggressive anticoagulation. And that's a decision that your doctor has to make at the bedside. There are a lot of risk factors for severe COVID-19 disease, and these are the comorbid conditions, that we talk about. And as you might guess, the more you have, the worse you do. And like I tell my residents and students, the more of these you have, if you fall out of a tree, the worse you're going to do as well. So, any serious insult to the body, the more problems you have, the worse you do. So, but, the big ones I think are age, diabetes, sickle cell, heart failure, and obesity, and COPD. You got bad lungs, and then you get something worse on your lungs as well, you're going to do more poorly. That's why you get your flu shot. And the laboratories that your doctors will monitor are quite numerous, and these are monitored every day or every other day or every third day, depending on how well the patient's doing. And these are kind of in a class of what we call acute phase reactants. And so if the patient's not responding, many times what it looks like happens is the body's inflammatory reaction gets out of control and sends a signal to the body to shut down, if you will. And so there are interventions that can be done to try to blunt this, what we call cytokine storm. And there are proteins that can be given that will neutralize some of those cytokines. And those are kind of last ditch at this point in time, but they are available. And now, frankly, I've been a little disappointed in their use and in the results of their use, but seen some kind of short-term gain, but long-term not so good in my limited experience with that. But so a lot of them. So your doctors, they monitor a lot of things: blood gases, creatinine kinase, ferritins, troponins, all those kind of things to keep a good handle on the patient. Okay, so despite all these things, we sometimes lose. And as you know, the death rate in the state of Michigan is 5%, generally 7,000 deaths in about 142,000 cases. Now, I will say this is cumulative, and it's cumulative from about late March. So our knowledge of this has improved dramatically over the last, 6 months. We know about steroids, we know about blood clots, we know about a lot of other things. And so our mortality rate is much less now than it was, but overall it's 5%. And the thing that is also puzzling and problematic is the over-representation or the increased numbers of African Americans in Michigan that have become ill with coronavirus. And it is, about double the number of whites, but it's not explainable very well. There are obviously physiologic things that one might consider, but there are many, many sociologic things, and those probably take precedence in terms of access to healthcare, jobs that people work in, public transportation, perhaps, many, many of those other factors. And those research studies are being carried out to try to figure out exactly why this is and how to fix it. Deaths also overrepresented in the African American community, about 1,700 per million here in Michigan, as compared to about 500 or so for the white population, and about 250 for many other subsets, although the numbers are much smaller in those situations. So we really do need to have better understanding about why this is going on, and honestly, if it's still going on. And as I mentioned before, age group is very important here. Again, from April 1st, if you were over 80, you had about a 40%, 34%, excuse me, chance of dying, as opposed to if you're 20 to 29, only about a 0.1% chance of dying. So there are many, many variables in there that seem to influence outcome for patients. Now, I said before that was from April. I took the last 6 days or so. This was just what my computer would print out. And, the number of confirmed cases per day has really dropped down to about 500 per day. It's been pretty stable at that. And our deaths are actually in about that 10 to 15 range per day. And so, again, we've improved our ability to treat these people, and mortality rates are substantially less. And if you consider our Michigan population is 10 million, this is about 0.005% per day, right, on a 6-day average. And this is about 0.00001 deaths in the population per day based on the 6-day average. So it's not particularly high in terms of overall risk to the general population. Okay, so the numbers are really pretty low when you start talking about quarantine and those things. But don't forget the painful lessons. Okay, here's where we are now in terms of the hotspots for COVID-19. This is cases per 100,000. You can see the cases in like New York and Michigan and Pennsylvania and New Jersey, the original hotspots have all pretty much tampered down. So Florida, tamped down considerably. Wisconsin, reasons I don't quite understand, is now red hot. But a lot of other places, even California, is much less than you might expect. So this evolution of SARS-CoV-2 continues, and hopefully I suspect it's just going to burn itself out. You want to know the truth. So if you don't learn from the past, though, you're destined to repeat it. And I want to bring up those painful problems that almost destroyed the healthcare system in April and May. There's a quote from a New York City pediatrician in March who is a friend of one of my fellows. And basically her quote was that there are dead bodies lining the hallways in the emergency room because all the freezer trucks are full. We have 51 dead on average per day now in the emergency room. And I'm seeing 65-year-old patients. The painful reality was people were thrown in refrigerator trucks, in bags, and in makeshift morgues with 2x4s and plywood because there was no place to go. So we shouldn't forget those lessons. Those are very painful, and we don't want it to happen again. Okay, the last portion that I want to do in hopefully 5 minutes or so is treatment options and challenges. These are the possible treatment options and the politics. I love the politics. I love the treatment options too, but the politics is funny. Steroids shown to improve survival in multiple trials. Chloroquine and hydroxychloroquine, not effective. A question mark. And why do I say question mark? Well, the two trials that were published in the New England Journal of Medicine and the Lancet, the two premier journals in the world, were both retracted, saying that hydroxychloroquine didn't work. And they were retracted because the data was flawed. And it was flawed because it came from some sort of a public data mining company. And nobody really looked at it. Believe it or not, this is New England Journal of Medicine and the Lancet. Nobody looked at the data originally other than the guy that was providing it to them from the company. And some of the data apparently that he provided included every patient in the whole country, which we all know would be basically impossible. So those two trials were now retracted. Unfortunately, what that did was it stopped enrollment in all the other trials. All the money was taken out of those trials and put someplace else because we knew the answer. So should I say that I think hydroxychloroquine and chloroquine are helpful? Probably not. I was not really particularly impressed. However, the science now has been redacted. Other drugs, viral drugs, antiviral drugs, HIV protease inhibitors, not effective. Remdesivir can decrease hospital length of stay. Serum from survivors. This is a interesting idea. Frankly, this is what they did in the 1930s, and we have much, much better things to do. This is basically monoclonal antibodies, which is what the president got, Regeneron. It was a cocktail of monoclonal antibodies. This is, monoclonal antibodies with a 1930s hat put on it. It's not going to work. Serum from survivors. I mean, it's just not going to work. You can't practically do it. But anyway, that's my opinion. Angiotensin receptor blockers, not effective in clinical trials. As you saw, the ACE2 receptor is what we're talking about for the binding. Zinc unknown, vitamin D unknown, cytokines unknown. This is part of the remdesivir confusion. Basically, in April, Dr. Fauci said that remdesivir has clear-cut, significant positive effects in diminishing the time to recovery. And again, I got no problem. If you can decrease length of stay by 3 days on the stress of the healthcare system back then, that's a clear improvement. There was no improvement in survival though between the two groups, and that was noted. Same day of that announcement though, the Lancet, which I mentioned before, published a study which said remdesivir did not speed recovery and did not reduce deaths. Okay, and then in JAMA just a few weeks ago, they did a trial, 5 days or 10 days of remdesivir, and that was no better than standard of care. Well, you got to remember, we now know standard of care is steroids and other things. And so maybe the minimal improvement that you got with remdesivir is not as impressive when you have a better standard of care. Okay, so here's the painful truth and the early truth. Okay, we'll try to go through these fairly quickly. The early truth. SARS-CoV-2 is spread by cough and droplets in close contact. We know that's still true, but we also know that SARS-CoV-2 is spread by asymptomatic patients, okay? You don't have to come into close contact with somebody that's ill. You can have contact with somebody who's asymptomatic and pick up SARS-CoV-2. Second point, asymptomatic transmission unlikely, definitely happens. We know that happens 5, 10, 25%, depending on what study you want to do, or what study you want to read. This number of people will acquire illness from an asymptomatic person. Next thing, infectious droplets only occur 3 to 6 feet from the patient, and you only need droplet isolation. Well, as we've all read in the newspaper, infectious particles sometimes found 20 feet from the patients, and there's possible airborne spread in poorly ventilated rooms. CDC has now changed its position 4 times on this, and they keep going to this poorly ventilated area. And I was thinking about that. Yeah, I can't go backwards. But anyway, I was thinking about this poorly ventilated thing. I mean, my house, when I have the fireplace on, we actually have to open a window because there's not a lot of extra air coming in from the outside. For heat, we've kind of, the house kind of got wrapped in one of those Tyvek things, and there's not a lot of air that moves around. I wonder if I have a poorly ventilated house. But anyway, like I say, CDC's changed their position on this 4 times so far, and that's the painful truth. No transmission by oral route. This is probably not important. And the time to illness, after illness to being non-infectious, generally 7 to 10 days. Virus dose secretions can go 14 to 21 days in some people, and I think it would be prudent to not be cavalier about those last 7 days. The early truth, social distancing is needed, and we may be able to lift the distancing by Easter. I think you all remember President Trump saying that. The new painful truth, I'm afraid, is social distancing is going to be in place for years, and unfortunately, it may be in place forever. I don't know. I don't see it going away anytime soon. Next, early truth, masks were not recommended. I think we can all recall that, how WHO said yes, and CDC and NIH said no. Well, now we know masks are important to decrease spread. So there's been some backtracking on both of those, and it's just the way it is. That's fine. We've learned, again, keep in mind, as you learn things, you don't make the same mistake twice, right? Hydroxychloroquine works in the lab. It's going to work for people. Hydroxychloroquine does not work in the early or late treatment ? As I just mentioned, there are 2 studies that were hallmark studies, quote unquote, and shut down. All the other studies have been retracted. And now everybody's kind of scratching their head because in vitro, the stuff does seem to do a little bit of work. And I even believe France said it's okay to use it again. Remdesivir, same thing, works in the lab. It's going to work for people. This drug has been very disappointing, and it's only decreased length of stay in 1 study. That can be important when your hospital's bulging with COVID-19 patients, but it's not what anybody wants. Next, steroids should not be given. This came from a SARS study that said it was worse. So far, steroids are the only thing that's been shown to improve survival. That's the new truth. And then the unknown unknowns, we know your prone position people, and the unknown unknown, I say that unknown unlikely, vaccine ready in October. I don't think that's going to happen. So I've gone a little bit over time. Thank you all very much, and I'm happy to answer any questions.
Great, thanks, Dr. Havlichek. That was a lot of really great information. We do have
probably too much.
we do have a few questions. One being in regards to what you were just talking about. Someone mentioned that there possibly are some newer studies out there on hydrochloroquine, and that it's important not to exclude them. Do you have any thoughts on that?
Yeah, there are thousands of studies out there on various things from transmission to treatments. I agree 100%. We don't want to ignore any study. And it's gotten so difficult to figure out, is a peer-reviewed article better than a non-peer-reviewed article? I mean, I was shocked when the New England Journal of Medicine had to retract their article because of sloppy work. And that's what you expect in a peer review. You expect them to pick that up and reject that article. You know, yeah, I agree. Whoever said that, I agree that hydroxychloroquine, in my opinion, the decision is not yet out on that, not final. The jury's not out. The jury's still out. The jury's not back.
And did we ever fully establish a quarantine to say, and if it worked or not?
Well, see, that's the thing. Nothing is done in isolation. And that's why when I was kind of dancing around the question of masks, masks are not done in isolation. Masks are done with social distancing, with hand washing, with closing schools, you know, with changing behavior in grocery stores where people move one way or the other. And then you say, yes, it's the mask that did that. Well, you know, it's not just mask, it's all of it together. Quarantine would be part of that. If you're not going out and not spreading the virus to other people, then you will heal. I would argue within, 80, 90%, 21 days, and then you will be fine. And so you should quarantine while you're sick. I don't know if that quite answers the question or not, but yeah.
Are those patients who continue to be symptomatic at 2 months still spreading SARS-CoV-2?
Yeah, that's a good question. I don't think we know if they're still spreading SARS-CoV-2 or not. I've had a couple of patients who were still positive by PCR, 6-8 weeks later. And so I think the best advice would be to treat them as though they are still spreading, even though we don't know that to be the case. And the reason I say that is the PCR test is so sensitive that you can pick up just very, very small numbers of viral particles and have it be positive. And you can even pick up sometimes fragments of viral particles that aren't infectious, and they'll still be positive test. So, the people that are still symptomatic at 6 months, or at 6 months, at 6-8 weeks, I think they should have a PCR test to decide, that kind of infectiousness. It may just be that their lungs are scarred and damaged. I mean, if you have a, bad knee trauma from a football injury or from a soccer injury or something like that, your knee never is going to be quite the same again. And if you have a really bad damage to your lungs from an infection, your lungs never may be the same way again either. So, it's possible that they aren't infectious, but they just have a lot of scar tissue in their lungs.
Great. Can you compare the currently available antigen tests, especially the rapid test versus the PCR test?
I cannot. I just saw yesterday that the rapid test was approved, and I don't want to wade into that because that is one thing I haven't looked at.
That's okay. Is there any value in the argument that we're only prolonging the pandemic by trying to stop it? In other words, should we just let the pandemic burn itself out while also protecting the most vulnerable to build herd immunity?
The Sweden protocol. That's as I understand it, that's what Sweden's doing, still doing. They've been doing it since this all started. They think that's the best thing to do. I have heard that, it didn't work well in the beginning at all, and they had a lot of deaths. And now I'm hearing that they've got a pretty good response, so things are going pretty well. I don't know. That's one thing that I would assume CDC is looking at data that I don't have, and looking at data. Nursing homes are just hotbeds of COVID. But from the data that I have, I would say that's not a good idea. But I don't have the Swedish data, so.
Perfect, thank you. This person says that they read that those who had tested positive for SARS-CoV-2 had natural immunity for up to 3 months. Is this accurate?
Probably. Yeah, I would think that if you've had the disease, you'll be immune for some months. The problem is that's not very long. 3 months is not, long. I mean, we've been 6 months into this now. So there are cases where people have gotten infection more than once. And the theory is that they got infected with a different strain of the virus. I think the jury's still out on the effectiveness of the antibody response for this, but it does. I do honestly think it helps. Again, I wish it helped more. I wish it was more effective and lasted longer. But I do think that right now the information is months that this protection will probably last, not years.
Great. And then we had a couple questions that were submitted to us prior to tonight. And so I'll ask these and we'll see if it was already possibly covered. Number one is how regular testing is encouraged on campus and satellite campuses. So this person's a faculty member in Grand Rapids and not encouraged to use Dr. Lipton's saliva test regularly. What testing data for this test, sensitivity and specificity, has been established so far?
I don't understand the question. Which test are you referring to?
Dr. Lipton's saliva test.
Well, it's a research thing. I don't think he knows yet. Does he? I mean, he's doing the research. It's a great idea. I got no idea, or I got no objection to doing the research. I think it's a great idea. I don't think he's to the point, though, of having sensitivity and specificity. Maybe he is, and you should just forward that question to him.
And then our last question is, could you elaborate a bit more in detail about higher risk circumstances versus lower risk circumstances for indoor settings? Since cold season is approaching, what have current report studies shown in regards to gyms, classrooms, stores, offices, meeting a couple people at home, restaurants?
All of the above. Can you repeat the question again? What do they want to know? What does the person want to know?
I believe what she's trying to say is that, can you talk a little bit about some of those risks with the different things? And I think, partly those are the things that are still in question, but perhaps you can elaborate a little more about how risky those behaviors are.
Well, it's all, I guess I would just say it's all probability. If you're with your family and none of your family have, COVID or infected with SARS-CoV-2, then your risk is 0. If you go to a restaurant and you're with 10 other families and one of them has, SARS-CoV-2 and they're coughing and they're right next to you, then your risk goes up, I guess I would say substantially. I can't give you a number on something like that. There's obviously, epidemiological, I would say outliers, kind of like that choir in Washington, that example. I mean, that's a, way kind of out on the edge example of somebody infecting, 53 or 58% of the people in that room. So it's just a kind of a probability, you know, what's the probability of you getting exposed? That probability means what's the probability of being next to somebody who's coughing or sneezing? What's the probability of them being a super spreader? You know, it's very complicated. I don't, you know, I agree with the question. It's very complicated, but there is no simple answer on that one.
Great. And during that time, a couple more questions came in, so we'll just touch on a couple more things before wrapping up.
Sure.
This person's asking, will the flu shot help with not contracting COVID?
Will the flu shot?
Yes.
Flu shot will help you not contract the flu. It will not do anything to help you with COVID. Now, you know, that's easy. We don't have any evidence that the flu shot will help you avoid COVID.
And then based on the information available, where do you see the US pandemic-wise this winter and spring with COVID, the flu and the common cold? And I know I'm asking you to speculate on that, but they're just wanting your opinion.
Sure. No, I understand that. I appreciate that. I think the flu, I'm keeping my fingers crossed, will be less this year because everybody is doing the things that will prevent spread of flu. Social distancing, wearing masks, hand washing, kind of all that other stuff. And if our understanding of influenza transmission is correct, then the flu season hopefully will be less this year. Okay, so I'm hoping for that. We need a break. You know, one of these times we need a break on something. What's going to happen with COVID this year? You know, honestly, I don't know if I'm getting just a little bit jaded or jaundiced about the whole thing or not, but I don't know if it's just not burning itself out, frankly. I mean, it started in New York and Detroit and East Coast and, you know, Detroit area, went down to Florida, was really hot there for a while. Now it's not. But it wasn't in Wisconsin. Well, now it's in Wisconsin. And then my guess is in 4 to 6 weeks, it'll drop down there. And at some point, I think it will go to a baseline rate of X that we haven't predetermined yet. I don't know that we can do that, you know, scientifically at this point, but it seems to me that we're going to have a baseline rate of COVID infections with us for quite a while. And I believe a vaccine will help. I believe our treatments are going to be much better with the drugs. There's going to be some drugs actually that come out that are effective against COVID. Antibodies, monoclonal antibodies are going to be helpful, expensive but helpful. And steroids. We already know steroids, and they're dirt cheap. They're pennies a pop. So that would be my guess.
Great, thank you. And that was our final question. And so that wraps up tonight's lecture, unless anyone else has anything that they want to add. Okay, I think that that's a wrap. We're only a few minutes over 7:30. Thank you so much, Dr. Havlichek, for being with us tonight and for talking on this really important subject. And we have other lectures, so please check our website and our events page to see what other things you can join us for.
Okay, my pleasure. Thank you.
Thanks,
Thank
Doctor.
you.